Good evening, everyone. Thank you for being here. My name is Leslie Keefe, and I'm the Vice President of Corporate Development for Southwestern Vermont Healthcare. We're delighted to host Dr. Evan Grove from Dartmouth-Hitchcock for this special presentation on keeping the beat, improving quality of life through electrophysiology. It's my great honor and pleasure to introduce to you Dr. Scott Rogie, who is the Medical Director of Cardiology at Southwestern Vermont Medical Center. So thank you and enjoy the program.
Thanks, Leslie. Thanks, everybody, for coming. I see people with pencils in hand ready to take notes, so that's a good thing. A couple introductions. Dr. Anisman's in the back, my partner down in SVMC. Arlene Law, please stand up. She's one of our nurse practitioners. Patty Ryan runs cardiac rehab. I think some of our patients are here and have been through cardiac rehab. So what we're going to do, Dr. Grove is going to speak, and then we're going to do a question and answer afterwards. So if you could hold questions, and we'll get to everybody's questions after. So Dr. Grove, as you can see, is an electrophysiologist at Dartmouth. We work closely together. He's been a terrific resource for us. Dr. Grove, I think, has a slide on his CV. He's been at Albert Einstein and Osler and Johns Hopkins, so the best places. And he is going to talk about AFib and a little bit of potpourri about electrophysiology. So we're excited he's here, and I'll turn it over. Do you have a microphone? You have a
I think I need to hold this as separate. Thanks, Scott. Welcome, everybody. Thanks, Dr. Rogie and Leslie and Southwestern Vermont Healthcare and Southwestern Vermont Cardiology for inviting me to speak. And it's a true pleasure to talk with you about electrophysiology in general and touch on some topics that hopefully are a little bit familiar, but maybe some new things as well. So I like to, electrophysiology is a bit of a black box for even other physicians in the medical center that I work with and patients. And so I'd like to touch on what it is we do exactly, what is electrophysiology, and then also what can I do, what can we all do as citizens to use electricity and electrophysiology to hopefully improve our own lives and the lives of others. I'll mention in my talk the concept of shared decision-making. That's an idea that we try to employ often at Dartmouth-Hitchcock Medical Center and in the field of electrophysiology in general. I think a lot of medicine has moved towards this shared decision-making. I'll touch on that more, and then I'll include one patient story during the talk. There are over 2,000 electrophysiologists in the country. It's a growing field with new developments every year, but it's been around in earnest for the past 30 years, and we primarily work with different types of heart rhythms. And heart rhythms can be fast, slow, or irregular. And abnormal heart rhythms are also called arrhythmias or dysrhythmias. Some arrhythmias cause patients to feel poorly. Others may not be noticed at all. And some heart rhythms, even if they cause patients to feel terrible, are not life-threatening. They are merely bothersome, whereas others that a patient may not even perceive can cause them to pass out or even die suddenly. How does one become an electrophysiologist? I attended Albert Einstein College of Medicine for 4 years, followed by 3 years of residency in internal medicine at Johns Hopkins in Baltimore, followed by another 3 years of cardiovascular medicine at University of Maryland in Baltimore, and another 2 years of cardiac electrophysiology at University of Maryland. And this is how I spent many of my days in fellowship looking at electrograms. And then in December of 2017, I began my career as an attending electrophysiologist at Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire. Electrophysiologists see patients in clinic, patients who are sick and admitted to the hospital, and we perform procedures in the Electrophysiology Lab. An abbreviation for electrophysiology is EP. This is an EP lab in Australia that looks like the EP lab at Dartmouth-Hitchcock that I work in and my colleagues at Dartmouth work in. And most of our work is done with wires and catheters or plastic tubes placed inside a patient's heart. We reach a patient's heart by following a vein or artery on its course back into the heart. And underneath that long blue drape is the patient. See if that works, yep. And at the patient's head is an X-ray machine. That's what we use to see those wires and catheters inside the patient's heart as we move them around. There's also an anesthesiologist. He's making sure that the patient is comfortable during the procedure. For some procedures, the patient is under general anesthesia, totally unconscious. Other procedures are done with twilight sedation or conscious sedation. And other procedures are done with local anesthetic only. We keep the patient awake. Okay. And in the electrophysiology lab, we can work to prevent abnormal heart rhythms from arising within a patient's heart, eliminating symptoms and potentially prolonging their life. We gain access to the veins and the arteries by first inserting a very skinny, sharp needle into the blood vessel, then a wire, and then a big, it's like a super IV called a sheath over that wire. And through that sheath, we can insert our catheters and wires into the vein and snake them up into the heart. And we may enter a vein down in the leg, or in the shoulder here, or at times in the neck. During procedures, some of which last for 8 hours or more, we wear lead in order to protect ourselves from the X-ray radiation. This is an EKG, a 10-second snapshot showing how electricity moves through our heart. This is a normal EKG, which always gives me a nice feeling. And our heart contains a pacemaker in its top right chamber. Let's see if I have that picture for you. So this is where our normal pacemaker lives, in the top right chamber of the heart. And it sets our heart rate and starts a wave of electricity that spreads from right to left and from top to bottom. And it spreads around the heart, around most of the heart, in a kind of a wave-like fashion until it gets to the middle of the heart. So you see this little bright spot right here. That's like a junction box in the heart. So most of the heart is, the top and the bottom are insulated from each other. And all this electricity comes down to the center and then shoots down into the bottom part of the heart. This is all done in a very coordinated fashion normally, and it causes the heart to beat together, all the chambers to beat in sync with each other. And so your heart can supply blood to your brain and the rest of your organs and help you live your life. But you may want to see an EP if you have a slow heart rhythm, so that pacemaker is going too slow. Sometimes that can cause people to feel badly. Or a fast heart rhythm, so this is where the patient's pacemaker is overtaken by an abnormal fast heart rhythm. Or if you have an irregular heart rhythm. So this is a kind of a chaotic, disorganized heart rhythm that can make people feel poorly as well. This slow heart rhythm, if it causes symptoms, may be treated with a pacemaker. 60 to 70 years ago, a patient was required to push his pacemaker around in front of him as it was plugged into the wall, and he probably could only do so within the confines of a hospital ward. But in 1957, we saw the advent of the first wearable pacemaker. And over the years, they've evolved so that the battery and the computer unit have become much smaller and implanted under the skin. And we pace the heart through wires that are connected to that battery on one end and are in the heart on the other end. In the past several years, technology has continued to evolve so that this pacemaker is only about the size of a fingertip and it's not connected to any wires at all. It's merely located within a small area of the heart. This is called leadless pacing technology, and leadless refers to the lack of wires residing within the patient's veins. Now, these days, most patients who require permanent pacing do still benefit from this type of pacemaker connected to wires that are screwed into the heart here. But some patients that we've seen at Dartmouth-Hitchcock are appropriate candidates for this leadless pacemaker right here, this very tiny, very small self-contained unit. And we implant those at Dartmouth-Hitchcock, and our patients have done very well. In the past several years, it's projected that we'll hopefully be able to use this leadless technology for all these patients here that normally would receive pacemaker wires in the veins. And recent research has shown that this leadless technology helps to prevent infection. And while infection is uncommon with pacemakers, we'd like to make it more uncommon. Another picture. This type of pacemaker is delivered through a vein in the leg. We take a special catheter to push the pacemaker up against the side of the inside of the heart. We let it go, and we take this whole plastic catheter out, and we just leave this little unit behind. Here again is a normal EKG. Here is an abnormal EKG. This is a fast heart rhythm called ventricular fibrillation that quickly leads to loss of consciousness and too often sudden death. Loss of consciousness and sudden death occur because this rhythm is too fast and too uncoordinated for the heart to beat effectively and to deliver blood to the rest of our body. One method of treating this heart rhythm is with a defibrillator. So 2 of these 3 gentlemen went to my last talk, so you would expect that they'd be sleeping. But the 3rd gentleman, he doesn't look too good. He may be suffering from this abnormal heart rhythm, ventricular fibrillation. And this is where we all can come in and help our neighbors. And because defibrillators don't require an electrophysiologist to use all the time, they are available for public use and are crucial to improving survival in out-of-hospital cardiac arrest. So public use defibrillators are called AEDs. And if you see this gentleman on the subway or in the coffee shop or the airport, and he's not responsive, and he doesn't seem to have a pulse, then what you can do is look for this AED box. There's usually pretty good signage out here. And grab the AED, open it up, it talks to you, and there are really simple directions written on it, and apply pads to his chest, and it will tell you if he's having a dangerous heart rhythm or not, and if he is, to give him a shock. And research has shown that by doing so, you give him at least twice as, you improve his chance of survival by at least 2 times, and can help prevent permanent disability due to out-of-hospital cardiac arrest. There have been studies all over the world, but a recent study in 2019 took place in England where they made a conscious effort of planting these defibrillators all around their town, and they've shown in just in the past year that they've improved survival of out-of-hospital cardiac arrest and reduced permanent neurologic disability due to out-of-hospital cardiac arrest. The American Heart Association and the American Red Cross have lots of information on their websites about automated external defibrillators, and they also offer hands-on training in how to use those. Defibrillators can also be implanted by an electrophysiologist. Modern defibrillators work by sensing a dangerous fast heart rhythm like ventricular fibrillation or others, and then terminating it, usually with a high-energy shock delivered across the heart. 70 years ago, to use a defibrillator required that the patient's chest be open and that these metal spoons, I think the first defibrillator was literally using spoons from the cafeteria, and you put them on the patient's heart and deliver that shock. But these days, over the years, that technology has evolved. We went from here to implanting defibrillator patches directly on the heart during open heart surgery. Again, a very invasive procedure, but those worked well. And now we put a defibrillator through the vein, just like similar to a pacemaker, so that this defibrillator is lying within the patient's heart. And the outside portion of the defibrillator is underneath his skin. Defibrillator sizes have also gotten much smaller. And in the past several years, new technology has emerged. This is called the subcutaneous defibrillator. Some patients are because of certain characteristics. They may have had a heart attack in the past, or they may have a weak heart condition called cardiomyopathy. Those patients may be at higher risk for dying suddenly from a dangerous heart rhythm. And for those patients, they are oftentimes excellent candidates for this new type of technology, subcutaneous defibrillator. This defibrillator is implanted just underneath the patient's skin. So it's not inside the blood vessel, it's not inside the heart. And it has been proven to work just as well as defibrillators planted inside the chest. But it does avoid the potential risks of damage to the blood vessels inside the chest and infection of the heart. And this type of defibrillator is implanted through an incision on the patient's side and a second incision at the bottom of the breastbone. There used to be a third incision made, but oftentimes we don't have to make that third incision. And we implant these defibrillators at Dartmouth-Hitchcock, and our patients have overall done well. Some patients do have a little bit of discomfort due to the battery that you can see on the side. They sometimes feel it with their arm as they're walking or lying on it. Aside from implanting devices such as defibrillators and pacemakers, electrophysiologists perform electrophysiology studies in order to learn how electricity moves throughout a patient's heart. Does it move too slowly? Is the patient at risk for having a very fast heart rhythm? Were they born with an extra electrical connection that can lead to an abnormal heart rhythm? And an EP study is performed by putting in catheters through a vein in the leg. We bring those catheters, often 5 catheters at once, into the heart. So we have one catheter in the top, one in the bottom, one over on the left side, on the other side of this screen, the left side of the heart, and then one in the middle of the heart. And we look at the electricity using those catheters as it moves through the heart on a screen like this. So oftentimes we make it really nice rainbow colors, and we see we can watch electricity as it moves through the heart. And this looks like a normal electricity. If we see evidence of an arrhythmia during an electrophysiology study, we can oftentimes eliminate the arrhythmia through what's called an ablation. We traditionally eliminate abnormal heart rhythms with heating of the heart tissue. So what we do is we deliver radio frequency ablation, a current of energy from the tip of this catheter to a metal patch on the outside of the patient's skin. And what that does is it heats up the heart tissue that the catheter is sitting on, and it causes scar tissue. So this is a slice of heart, and this white spot here is where ablation was performed. That's scar tissue, and that's surrounded by normal, healthy heart tissue there. And by performing that ablation, we eliminate abnormal heart rhythms coming from that spot in the heart. Some arrhythmias, like supraventricular tachycardia, that fast heart rhythm that I showed you a few slides back, can be cured with ablation procedure. The cure rate is about 90 to 95%, depending on the particular rhythm. Other types of arrhythmias, like atrial fibrillation or ventricular tachycardia, a dangerous fast heart rhythm from the bottom of the heart, can be reduced, oftentimes almost eliminated with ablation. That's ablation through heating. There's also what's called cryoablation. That's ablation through freezing. So down here is a picture showing, again, that heating process to cauterize or create scar tissue within the heart to eliminate an abnormal heart rhythm. And on the top here, the same end is achieved through freezing. So how that is done is we will put a catheter, or in this case a balloon, into the heart, and we inject pressurized nitrous oxide into that balloon, and that freezes the tissue down to about 70 degrees below 0 Celsius, and that kills that heart tissue and prevents it from conducting electricity, eliminating heart rhythms. And this is just an example of, this is where somebody took a slide, a very close-up view of an ablation lesion within a patient's heart. And this is an ablation done through heating, and this is an ablation done through cooling. And the cooling, you can see, it's a little bit neater, isn't it? It's more of a straight line between the scar tissue and the normal tissue. And that just goes to show that for some heart rhythms, particularly ones that may be a little bit riskier to ablate, we use this cryo, this freezing ablation in order to prevent complications as much as we can. Okay. So now I'd like to speak about a patient of mine that I saw just shortly after starting at Dartmouth-Hitchcock. She's a 77-year-old woman. She was referred to me because of a history of a very common irregular heart rhythm, atrial fibrillation. She had known about her atrial fibrillation for several years, but it just occurred sporadically. It wasn't too much of a problem for her until it came on a few months before she met me, and it stuck around with her. And she actually, she saw her primary cardiologist about the atrial fibrillation. He performed a cardioversion procedure for her. But unfortunately, the atrial fibrillation recurred in less than 24 hours. So she wasn't able to stay in a normal rhythm anymore. And she had a history of depression and thyroid disease. But she found she could no longer walk her dog. She could, walk to the mailbox, but anything more than that was difficult for her. And she wanted to avoid medication. Now, when I saw her, I was a little unsure of how to manage her atrial fibrillation. I was a little skeptical, to be honest, for a couple reasons. One was her atrial fibrillation was tough to get rid of. So she was in it. She was persistently in it despite going through a procedure to get her back to a normal rhythm. And she had other reasons for feeling poorly. And so I evaluated, she had some shortness of breath. I evaluated that with some lung testing. And I said, well, let's just take our time and see what we can do. In the meantime, she knew walking into the office she wanted an ablation procedure to get rid of her atrial fibrillation, but I was a little hesitant. So before continuing on with her story, I'd just like to talk a little about atrial fibrillation. It's the most common arrhythmia seen in clinical practice. Globally, the prevalence, this was in 2010, is about 34 million people. In 2010, there were about 3 million Americans with atrial fibrillation, and it's estimated that by 2030, about 12 million Americans will have atrial fibrillation. And the risk for a 40-year-old in the United States is about 1 in 4 that he'll develop atrial fibrillation at some point. Atrial fibrillation is more common with age. So atrial fibrillation is associated with certain medical conditions like diabetes and high blood pressure and other types of heart disease. But the most common risk factor and the strongest risk factor is age. And the population of the United States and much of the developed world is getting older. This is some data from the U.S. Census. In 2000, we saw, the median age was 35 in the United States, and there's some, expected older populations in Florida and Arizona, maybe up here in northern New England as well. And in 2016, we've all gotten a little greener, and you can see that the southern Vermont median age is 45 to 50, and the U.S. median age is about 38. So this is all just to say that atrial fibrillation is common, and it will become more common. So just to review, this is electricity as it moves through a person's heart. This is a normal electrical picture here. And Jimmy Fallon and his guest demonstrate atrial fibrillation. So a spastic, uncoordinated, really scary type of movement of electricity throughout the heart. And so this is atrial fibrillation. Basically, chaotic electrical activity in the top part of the heart, and the bottom part of the heart responds by beating irregularly and not always in the most efficient manner. And we've found that in the past 20 or 25 years, that atrial fibrillation, about 90% of the time, arises from the top left chamber of the heart. So this is the heart. This is the top right, top left, and bottom right. And the top left chamber, that's called the left atrium. And there's 4 circles right here, and those are called the pulmonary veins. And the pulmonary veins are blood vessels that take blood from our lungs back to our heart. And it's found that most of the time, that's where atrial fibrillation arises from. There's abnormal electrical activity in the pulmonary veins. Every once in a while, it gets out and affects the rest of the heart and causes atrial fibrillation. So why do we care about atrial fibrillation? The good news is that it is not a lethal arrhythmia. It doesn't cause people to die. It does not cause people to pass out. But there are two primary concerns that electrophysiologists have when we see patients with atrial fibrillation. One is that it's associated with an increased risk for stroke, and the other is that it can cause symptoms. Atrial fibrillation confers about a 5 times increased risk for stroke amongst all people who have atrial fibrillation. And what happens is that the top part of the heart beats uncoordinated in an uncoordinated fashion, and we think that blood pools within the heart and leads to stasis and clotting. But also it seems to be more than that, atrial fibrillation causes inflammation, it causes dysfunction of different types of proteins in the bloodstream, and all these things lead to blood clot formation within the heart. And this is an example of a blood clot that can form in a patient's heart. And if it breaks off and goes up a blood vessel and up to the brain, it can cause stroke, neurologic disability, inability to move an arm or a leg, and that can be permanent, potentially. We know that strokes due to atrial fibrillation are worse than strokes from other causes. About 60% of the time, folks have permanent disability, and about 20% of the time, a stroke due to atrial fibrillation causes death. The primary method of treating atrial fibrillation in order to prevent stroke is anticoagulant medication. So these are several different anticoagulant medications. Some probably look familiar from TV commercials and so on. But they reduce the risk for stroke by about 2/3. So they do a good job. But even though atrial fibrillation is in general associated with a higher risk for stroke, not all patients who have a high enough stroke risk that they require anticoagulation. And here are the primary risk factors that we consider when weighing the decision if a patient, would benefit from anticoagulation. Because taking an anticoagulant doesn't really make a person feel better, and it oftentimes is costly. It's a pain to take a medication every day. And it's all in the hopes of preventing an event that may or may not ever happen. The decision to start a blood thinner is oftentimes not easy. And that's where I think shared decision-making comes in. So that's a concept where a patient brings his or her values, goals, expectations to the table, and a physician brings her expertise and experience and knowledge about the different types of treatments to the table. And a treatment course is arrived at the end. Okay, and this is opposed to a situation maybe, hopefully many years ago, where a physician would just make a decision for the patient without really involving the patient and her values. The Dartmouth-Hitchcock was actually the home of the first Center for Shared Decision-Making, which opened in 1999. And these days, especially in the field of electrophysiology, because there are so many options for treating patients with abnormal heart rhythms, and oftentimes we don't really know the right or the wrong path. The Centers for Medicaid Services, they require that we use shared decision-making when talking with patients about their options. The most important thing for someone with atrial fibrillation is that she has this discussion with her physician. And of note, research in the past several years has shown that about 50% of patients who have atrial fibrillation are not prescribed anticoagulation, or maybe not even offered it. And so this may account for potentially treatable or avoidable strokes and disability and death. Because some patients are not able to take anticoagulation due to bleeding or sometimes other factors, an alternative strategy to prevent stroke and atrial fibrillation has been developed, and this is called left atrial appendage occlusion. And this was developed because most blood clots that form in the heart, in that left atrium that I showed you, form in a part of the heart called the left atrial appendage. and that's really kind of an off growth of the top left part of the heart. It can be cauliflower-shaped, so there's a cauliflower-shaped appendage. It could be windsock-shaped. That's a windsock appendage. It could be a chicken wing, or it could be a cactus. Okay? And, but most of these, whatever shape it is, most of these appendages can be plugged up with a device called the Watchman. And the idea is that this Watchman plugs up the hole to the appendage and prevents blood clots from forming inside there, and therefore you don't have a blood clot that can form a stroke. And the Watchman device has been shown to be non-inferior or as good as warfarin in preventing stroke, or warfarin is a type of blood thinner, excuse me. So for patients who can't take blood thinners due to bleeding, or if they have some other rationale for not taking a blood thinner, then a Watchman device may be appropriate. And what's done is, so this is the really blown up picture of the left atrium, the top left chamber of the heart. What's done is we take a catheter through the leg, just like our other electrophysiology procedures, and we deliver it into this plug here, that's the Watchman device, into the left atrial appendage, and we give a little tug on it to make sure it stays in place, and then we let it go. We take this catheter out of the body, and this stays here, and that prevents blood clots from forming inside the appendage. Dr. Megan Coylwright is an interventional cardiologist at Dartmouth-Hitchcock, and she's the director of the Watchman program. And so we work closely together with her because we see a lot of patients with atrial fibrillation and heart arrhythmias to determine who may be an appropriate candidate for the Watchman procedure. To quickly return back to my patient, she has no history of significant bleeding, and she's currently protected from stroke with a medication called apixaban. It's an oral medication that's taken twice a day. In addition to the risk for stroke, electrophysiologists also consider a patient if a patient has symptoms with atrial fibrillation. If a patient truly does not feel his atrial fibrillation, then oftentimes, once stroke prevention is addressed, the patient can be monitored without any further intervention. But if he or she feels poorly with atrial fibrillation, then doing something to keep her in normal rhythm is indicated. And symptoms can be tough to pin down, so they often occur along a spectrum. Some people truly do not feel their AFib. Other people feel as if they're going to die. They feel terrible. They immediately go to the emergency department. They know that something is terribly wrong, even though they're not going to die. Most people are somewhere in between. So they experience either shortness of breath, fatigue, palpitations, but they don't feel right. They don't feel themselves. What tools do we have to keep people in a normal rhythm? Medications are a good option for many patients. So these types of medications are called antiarrhythmic medications. Those are separate and unrelated to the blood thinners. But antiarrhythmic medications are not perfect. So about half the time, if you have a patient start an antiarrhythmic medication, they have about a 50% chance of being back in atrial fibrillation at 1 year. So it's not perfect, and they can be costly. It's not easy to take a medication every day, and many require routine testing to make sure that kidney function, liver function are working well. Ablation is another option, and ablation works well, particularly for patients whose atrial fibrillation comes and goes. It's been shown to be superior to medications. However, ablation is not without risk either. It requires an overnight stay in the hospital, and while 99 out of 100 times ablation goes just fine, there is some procedural risk to ablation. There are also lifestyle factors. So in the past several years, especially in Australia, there's been a great interest in what else can we do to help keep atrial fibrillation at bay for patients. So these purple blobs here are left atria. So those are the top left chamber of patients' hearts. And we make these purple blobs when we do an ablation procedure for a patient. how this is done is we have a catheter inside the heart. We move the catheter and we touch all the walls of the inside of the heart. And all the while, a special computer program is making this model in front of our eyes. And what the purple means, we have a special color code. So what the purple means is that for this patient, the tissue on the inside of the heart looks very healthy. So this is good. You want a purple blob. And they also are a non-drinker. But you can see with increasing amounts of alcohol consumption that there is more scar within the heart. So this red color right here is dense scar. That's scar inside the heart. And then the in-between colors, like yellow and green, are, it's not totally scar, it's not totally normal, it's somewhere in between. And this was reproduced among, many patients that had an ablation performed. The more alcohol, the more scar there tends to be inside the heart. We also know that the more scar there is inside the heart, the less likely somebody is to stay in a normal rhythm. So the idea is less scar is good. And so if I see a patient in clinic who drinks more than 7 drinks a week, I suggest trying to reduce the amount of alcohol consumed per week to try and limit the amount of scar within the heart. I don't think it's important to necessarily be completely abstinent, but probably the less alcohol, the better. Obstructive sleep apnea is a condition in which a person's airway closes on itself during sleep. Now the person, just like Homer here, he's not really aware that he's not breathing, that he's snoring, but it can happen many, many, many times throughout the course of a night. And oftentimes snoring, morning headaches, and daytime sleepiness are signs that this may be occurring. And this condition called sleep apnea can lead to atrial fibrillation and other heart problems. And the only way to diagnose sleep apnea is with a sleep study. So a person typically comes into a medical center or a clinic for an overnight stay. They get a bunch of wires hooked up to them, and they're monitored overnight. And if we find that he stops breathing in the middle of the night, then the treatment is what's called a CPAP, a continuous positive airway pressure machine. And that keeps the airway open and eliminates these apneic episodes where the patient stops breathing. It was found in several studies that by treating sleep apnea, if a person has atrial fibrillation, oftentimes the atrial fibrillation is reduced in frequency, and sometimes it can be even eliminated. What I typically tell patients is that if it's worth getting tested for sleep apnea only because you may be able to avoid an ablation, you may be able to avoid taking a medication if your sleep apnea gets treated. Not everybody tolerates the CPAP treatment well, but I had one patient tell me the other day that he felt like he was living his entire life in black and white until he got a CPAP machine, and then his whole world was color. I thought that was pretty cool. So it certainly does help many people out. So back to our patient. She was tested. She does not have sleep apnea, but her fatigue is worse. She had some lung tests that showed maybe she has some asthma. But again, when are you going to do my ablation? So after a few lengthy discussions, we decided to proceed with an ablation procedure, warning her ahead of time that I wasn't totally confident that it was going to help her out. So the ablation procedure for atrial fibrillation involves using heat energy, that radiofrequency energy that I mentioned, to draw circles around the pulmonary veins. And you could say we want to make the pulmonary veins like Las Vegas so that whatever happens in the veins stays inside the veins. So these veins could fire their abnormal electrical signals all day long, but it won't get out to the rest of the heart and cause atrial fibrillation. And this is a picture of her heart. So this is the top left chamber of her heart, the left atrium, and these are the 4 pulmonary veins. And these red dots are where I created the ablation lesions to draw circles around the veins and trap the electrical signals inside. This is looking from her back to her front. So this is the back side of her heart, and this is the front side of her heart. And you can see that the circles go all the way around there. And This is a voltage map like the ones I showed you earlier, the purple blobs. And this shows some purple down here, which is nice. But on the back side of her heart, there was a fair amount of scar. And, so the next morning, she did well. We talked about how the procedure went. And but I said, I'm a little nervous because I saw that you had this scar tissue. So again, I was cautiously optimistic. But she showed me. So 6 months post-procedure, she was in a normal rhythm. She was walking her dogs, going, wherever she wanted to go. She was. So I don't think I had mentioned this earlier, but her husband suffers from dementia, and so this played a large. At first, I was suspicious. Maybe this could be playing a role into her fatigue and why she was feeling so poorly, but no. So she was feeling like she was energized. She was much better able to care for her husband after the procedure, now that she's in a normal rhythm, and she felt like a new person. So I should have taken a cue from William Osler, but she did great. So that's really a success story. And in conclusion, I would say that we specialize in slow, fast, and irregular heart rhythms, arrhythmias. And these can be treated with implanted devices and ablation. You can save a life with an automated external defibrillator. Atrial fibrillation is a common arrhythmia that's going to become more common, and it can cause symptoms, but it is treatable, and shared decision-making can guide treatment. And we are happy to talk with you anytime about any concerns you might have, any abnormal heart rhythms. And that's it. And I can show you, my last slide here is the electrophysiology group at Dartmouth-Hitchcock. Paul Steiner, Kevin Kwaku, who's the director of electrophysiology at Dartmouth-Hitchcock, Raj Sangha, and so these are the veterans, so to speak. And then we have, I came on recently in December of 2017, and Dr. Emily Zeitler came on about a year ago. In August of 18.
Questions?
The question was, what about atrial flutter? And so atrial flutter is another abnormal heart rhythm from the top part of the heart, and it's really a cousin of atrial fibrillation. So they share many similarities. We think that it's associated with a higher risk for stroke, like atrial fibrillation is. But atrial flutter can be from the top left part of the heart, like atrial fibrillation is. That atrial flutter is sometimes more difficult to get rid of, but oftentimes atrial flutter can be cured. And it can be cured with a very simple ablation procedure, where we put a catheter, just similar to those slides I showed you before, in the top right part of the heart, and we burn a small line in the top right part of the heart, and that cuts the circuit of the atrial flutter. So to speak a little bit more about the differences, atrial fibrillation can be treated oftentimes with medication, as I mentioned, antiarrhythmic medication, and if sometimes people experience symptoms with atrial fibrillation and rapid heart rates, but those heart rates are oftentimes easily controlled with medication. Atrial flutter is a very organized, fast heart rhythm that oftentimes is almost impossible to control with medication. And so whereas atrial fibrillation, oftentimes I engage in a long discussion with a patient. You could try medication, you could try waiting to see what happens, you could try an ablation procedure. With atrial flutter, if somebody has it and it looks like the kind that's easy to get rid of, then I recommend an ablation procedure off the bat. Usually medications are not too helpful with that. Yeah, does that answer, is that helpful? Okay, yeah. The question was, so you say that atrial flutter is easier to treat or cure with ablation, and that's correct. So atrial flutter is oftentimes difficult, very difficult to treat with medication, but with an ablation procedure, it's oftentimes curable. Yeah. Okay. So two very good questions. The first one was, what about medication after cardioversion? Does that make sense? Do people need to take medication? So if somebody has a first episode of atrial fibrillation or hasn't been cardioverted before, they're pretty new to the arrhythmia, so to speak, then, and we do a cardioversion procedure, I think it's reasonable to not try an antiarrhythmic medication. The most important thing would be that for almost everybody who receives a cardioversion, they need to take a blood thinner for at least a month afterwards. But they don't necessarily need to be on long-term medication to control their heart rate. On the other hand, or heart rhythm, excuse me. On the other hand, if they've had atrial fibrillation for a long period of time, or they've tried a cardioversion before, or they've tried an ablation procedure, then I oftentimes put them on an antiarrhythmic medication, a rhythm control medication, because otherwise the cardioversion procedure is unlikely to work for very long. And that's in addition to the blood thinner medication. And your second question,
Left ventricle,
yeah.
the ejection fraction. Is AFib having an adverse effect on left ventricular ejection fraction? Thank you.
Yeah, that's a tough question, but I'll do my best. So most of the time, we don't think that atrial fibrillation causes the left ventricle to become weak, the left ventricle ejection fraction to decrease. It can occasionally, if the heart rate is really high in atrial fibrillation for a long period of time, sometimes that can cause the heart muscle to be weak. And that would be a reason to try and control the rhythm with an ablation procedure or a medication or something. But we do find that people who already have a reduced ejection fraction, they have heart failure, their heart squeeze isn't normal, half the time those patients have atrial fibrillation. And we do find that patients who have a heart failure do better if they're in a normal rhythm, as opposed to atrial fibrillation. And so if somebody has heart failure and they have atrial fibrillation, oftentimes we try and get them back into a normal rhythm. It's unclear really how aggressive to be. You know, do we do lots of procedures for a patient? Do we just try medication at first? But we're always thinking that these patients, we should try and get them back in a normal rhythm if we can. They often tend to feel better and they tend to have better outcomes regarding their heart failure. There was one more thing about that point is there was an interesting study published just a couple years ago called the Castle AF trial, which looked at ablation for atrial fibrillation in patients who have heart failure, who have reduced ejection fraction. And it was an amazing result that they found that people actually lived longer who had an ablation procedure. Now, it was such an amazing result and such a powerful effect the ablation procedure had that I'm a little skeptical about it, but it does, it has been shown in other smaller studies that ablation and trying to keep people in a normal rhythm with heart failure, they do better. Yeah. Atrial fibrillation? That's a good question. It seems to be, for most people, it's what we call multifactorial. There's more than one thing going on, and it's oftentimes a gamish of high blood pressure, maybe heart failure, inflammatory states like diabetes, sometimes valvular disease. So if you have a leaky mitral valve that's blowing blood backwards into the left atrium and causing that to dilate, that can lead to atrial fibrillation. So that's the most common scenario. About 1 or 2% of people seem to have a genetic variant that can cause atrial fibrillation. And then other folks have what's called lone atrial fibrillation, where they don't have high blood pressure, no diabetes, they're normal weight, they don't have sleep apnea, they don't drink excessive amounts of alcohol. They just have atrial fibrillation for no clear reason. Sorry. The question is, how is atrial fibrillation diagnosed? Is it done in the office or is it in the emergency department? And so it could be in any of these scenarios, to be honest. So some people who have atrial fibrillation but don't feel it, they don't feel any different, then the most likely scenario is it would be diagnosed in a doctor's office where they're doing an EKG and they happen to see it. Other times, other people feel absolutely terrible in atrial fibrillation, and so that brings them to the emergency department, and then you diagnose it there. And then the other thing is to note maybe is that, you know, an EKG is 10 seconds of a person's life, and so they may have atrial fibrillation come and go, but it may not be detected in the doctor's office, especially if they don't feel it. Yeah, good. So has anybody ever figured out why sleep apnea causes atrial fibrillation? I'm going to say no. A short answer would be no, but you know, some factors that are probably at play is that sleep apnea can increase pressures inside the heart, excuse me, and it can cause dilation of the upper chambers of the heart, and that can lead to fibrosis or scarring inside the heart. That can lead to so the larger the left atrium is, we find, the more likely a person is to go into atrial fibrillation. So a fun fact is that whales, we think, are in atrial fibrillation most of their lives because they have a huge left atrium, and it's just more substrate for the atrial fibrillation to catch hold. Whereas mice, so we do a lot of basic research with, I don't do a lot of research with mice, but electrophysiologists traditionally have done a lot of research with mice, and they're terribly difficult to get into atrial fibrillation. Their hearts are so small, and we think left atrial size is related to atrial fibrillation. So, and that can increase with sleep apnea. Also, sleep apnea seems to be it's kind of it's part of a global picture. So, oftentimes overweight leads to sleep apnea. Diabetes is related to sleep apnea, inflammatory states. And so all these things are probably working in concert to cause atrial fibrillation. So the question is ablation helpful for SVTs? And then what is an SVT? And SVT stands for supraventricular tachycardia. I could, let's see if I can just real quick get to the... So, and supraventricular tachycardia is an abnormal heart rhythm that comes from the top part of the heart. And, you know, I would say that for the most part, yes, it is treatable with an ablation, and we do ablation procedures for SVT all the time. The exact success rate does vary somewhat depending on the mechanism for the SVT. So here's a picture of an SVT, this middle side. So it's a very fast heart rhythm coming from the top part of the heart. That's not life-threatening, but it can be very bothersome for people. So some of these SVTs use an abnormal electrical connection in your heart that you were born with, and that electrical connection is you could think of it as we all have a wire, like the transatlantic cable that takes electricity from the top to the bottom part of our heart. But some people, let's see if I can get a picture of the heart here. Yep. And that normal connection lives over here in the middle part of the heart. But some people have an abnormal connection, you know, way over here on the side, okay? And you can actually, sometimes you can, if you take a heart out and you perform an autopsy, you can actually find that. You can get that little cable and you can isolate it. And if that's causing the abnormal heart rhythm, then that typically is very curable, about 90 to 95% of the time. Sometimes SVTs act more like atrial fibrillation. They come from the top part of the heart, and they're irritable areas of abnormal electrical firing. And those we can still get rid of oftentimes, but the success rate is about 70 to 80%. So kind of a cool fact about these SVTs is that I mentioned, you know, sometimes it can be over here on the side, this extra electrical connection. And the first ablation procedure wasn't an ablation procedure, actually. It was a surgical procedure where the electrophysiologist told the surgeon, okay, this extra wire is over here. I want you to cut it. And they opened the person's chest, exposed the heart, and the surgeon just took a knife with it on his finger and poked through the side of the heart to sever that wire and eliminate the abnormal heart rhythm. So nowadays, we don't have to do that anymore. We can do that with a catheter delivered through the leg and in the inside of the heart. The question was, who is a candidate for the subcutaneous defibrillator versus the one that's inside the vein, inside the heart? That's a good question. The typical candidate would be somebody who has never had an abnormal heart rhythm, but is at risk for having an abnormal heart rhythm. And typically we think of younger patients who, if we put in a defibrillator on the inside of the heart, may be living with that wire on the inside of the heart for the next 60 years or so. So if a 20-year-old comes in with sudden death, or if they're, for some reason, at very high risk for sudden death, then we think about putting in a subcutaneous defibrillator. Or if a patient has trouble or has disease of the blood vessels. So sometimes these blood vessels, these veins are clogged off, in which case we can't put a wire inside the vein. We need to put something on the outside of the body. Cases where you wouldn't, and another, a last factor to mention would be if they're at very high risk for infection. So if patients are at very high risk for infection, we don't want to put anything inside their heart if we don't have to, because then their heart could become infected. Bacteria could grow on that wire on the inside of their heart. People who are are not great candidates for the subcutaneous ICD are people who have had dangerous heart rhythms before, because oftentimes those can be treated with pacing from the inside, and that can only be done from the inside of the heart. It can't be done with a subcutaneous defibrillator. Or if they have an indication for pacing, if they need a pacemaker, then they would need a wire inside the heart. The question is there any difference in symptoms between AFib and AFlutter? And I would say no. In my thinking about my experience, some people truly don't feel either one of those arrhythmias, and there are people who definitely do, who feel very poorly in either one of those heart rhythms. The atrial flutter rhythm, just speak a little bit more on that. The atrial flutter rhythm, because it's easily curable with a very low-risk procedure, we oftentimes do the ablation, even if somebody doesn't feel it. And it's funny, they come back, I see them after the ablation procedure, and they say, oh, I didn't realize it, but I feel much better now. Like, the swelling in my legs is gone. I can walk further. But yeah, it's hard to predict who's going to have symptoms and who's not, yeah. Oh, that's an interesting question. So the question was, why are we seeing more atrial fibrillation? Is it because there's more diabetes? Is it because the population is aging? I think you were getting towards, if there's more diabetes in younger folks, are we seeing atrial fibrillation more?
Are you even seeing it in healthy younger people?
Yeah. Right.
Congestive heart failure, nothing else.
No, I think it's more. It's primarily due to aging, and I think I do see it in younger patients sometimes, in their late 20s, early 30s. And it's interesting that most commonly these are patients who have what's called lone atrial fibrillation. They don't have diabetes, they're not overweight, they don't have systemic illness, they just happen to have atrial fibrillation. But I think that's a minority of the patients that I see. Interestingly, just if we see a young patient like that with atrial fibrillation, we oftentimes think what else could be going on inside their heart. Oftentimes, or sometimes, those patients can have one of these abnormal electrical connections, and that can be causing atrial fibrillation. So sometimes we don't have to treat the atrial fibrillation itself. We get rid of that abnormal connection, and the AFib goes away. The question was complications of ablation procedure. So for atrial fibrillation ablation, there's serious complications occur altogether, maybe about 3 or 4% of the time, and those could include bleeding or damage to the blood vessels in the legs, poking a hole in the heart with one of those catheters, or stroke or heart attack. damage to those pulmonary veins that were burning around, so sometimes those can become narrowed. There's a nerve, a special nerve called the phrenic nerve, which feeds our breathing muscle, and that can be irritated with an ablation procedure. Sometimes, fortunately, those things occur very uncommonly, individually about 1% or less of the time. And then very, very uncommonly, 1 in 10,000, 1 in 5,000 cases, there can be a hole formed between the heart and the esophagus, our feeding tube that's behind the heart there. And that's a serious, that's an emergency, and that can sometimes be a fatal complication. The most common far and away complaint that patients have or complication that patients have is chest pain afterwards. And that happens in about a third of patients. And it's usually due to the actual ablation procedure. It irritates the sac that the heart sits in. But most of the time that goes away with either doing nothing, just it lasts for an hour or so, or with some Motrin and aspirin. Yep. Okay.
Great. Thanks so much.
Oh, yeah, you're very welcome.
Excuse me.
Yeah.
What is the connection, if any, between congestive heart failure, or I guess you'd just say heart failure nowadays, and AFib?
Yeah, so that's, well, there certainly is a connection, that's for sure. I think, so about, of people who have a reduced heart squeeze, so a left ventricular systolic dysfunction or cardiomyopathy, about half of those patients have atrial fibrillation. And for the most part, I think what's happening is the heart failure comes first, and that leads to atrial fibrillation. And it's probably a result of inflammation caused by the heart failure. And when folks have reduced heart squeeze, that can cause increased levels of hormones, certain types of hormones in the body that rev up the body, can cause atrial fibrillation. It can also cause pressures inside the heart to increase, and those, as I mentioned, I think in a question earlier, the chambers of the heart to increase in size, and that can lead to more atrial fibrillation. So it's very common for patients with a heart failure to have atrial fibrillation. And I think as I mentioned before, I think the important thing is if you see a patient with heart failure and with atrial fibrillation, we want to be asking, what can we do, or should we be doing something to keep them in a normal rhythm? Yeah. So the question was, if we think that somebody may have an arrhythmia, but it's not caught on EKG or a monitor or something like that, is there what else can be done? So yeah, there are other methods of trying to figure out, does this person have an abnormal heart rhythm or not? One of those is, and they can be non-invasive or they can be invasive. So and relatively non-invasive, I would say too. So one way is to do, sometimes, rarely people have arrhythmias that are produced by exercise. So an exercise test can always be tried. Most of the time that's not going to show too much, but that could be used. Another would be an extended monitor, like a 30-day event monitor is what it's called. If that doesn't produce anything, then an implantable loop recorder can sometimes be used. So that's that is put in a loop recorder through a procedure. A loop recorder is just, it's about this long and it's about this skinny. It's like the size of the clip on the end of a pin. And we put it underneath the skin, and it's like having a Holter monitor with you for 3 years. The battery lasts about 3 years. So it monitors your heart rhythm 24/7. And for people who have arrhythmias that arise rarely, that can be useful. And then there's also this electrophysiology study that I mentioned earlier. We can perform those to try and bring out an abnormal heart rhythm. So we can put in the catheters inside the heart. We can investigate, does this person have an abnormal electrical connection? We can irritate the heart. We can pace the heart to try and make an abnormal heart rhythm come out. So as an electrophysiologist, I oftentimes like to see something before I do an invasive procedure on a patient, but occasionally we will do this to get some more data. Yeah, and if somebody, thinking off the top of my head, so if somebody, the most common scenario that we would use this is if we think there's a life-threatening heart rhythm. So sometimes patients are at very high risk for having a life-threatening heart rhythm, but sometimes we need to prove it. So we take them to the electrophysiology lab, and we pace the bottom part of their heart and to try and produce a dangerous heart rhythm. And if we see that, then we say, okay, this person needs a defibrillator or some other type of treatment. Yeah. Oh, yeah. So the question is, how does age play into, I think, ablation for abnormal heart rhythms? So I don't have. I personally don't have an upper limit of age really when I see a patient. I think it's certainly when I see older patients, I do take that into account because I think they may be more prone to having complications from a procedure, maybe a little bit less able to tolerate an ablation procedure. But at the same time, I've done AFib ablation for 83-year-old and atrial flutter ablation for folks of similar age. As far as the effectiveness of the procedure, I don't think it really that is affected too much by age. It's more, I want to make sure that this is the right thing, this is a safe thing to do for a patient. Yep.